So again, a warm welcome to you all. Rhoda, thank you for that comment that we rock. That's really sweet of you. Thank you very much. So for those of you who are just newly in the room, we have 42 connections with us. Not too sure how many people, but we have about 42 connections with us today. Thanks for letting us know where you're from. We have people from Courtney and Fort Nelson and Campbell River and Dauphin, Manitoba. Dear James, you're such a loyal person who comes to so many of these. We really appreciate having you, as we have many loyal people. So we really thank you for your continued support. So with that in mind, we'll just say welcome and we'll introduce our session today, which is on employment for young adults and a focus on mental health, substance use and recovery. So we have some wonderful, wonderful speakers with us today, and we're very grateful to them for their time. And we'll just do the formal introduction as we usually do. We introduce you to dear Matt Lang, who's usually with me. So let me know how I'm doing today. I know I don't have a smooth radio voice. He's currently on an airplane and so unable to be with us today, but I know he's wished as well, and he's done lots of work in behind the scenes to make sure that we run smoothly today. Dear Jordan is our technology support. Hello, Jordan. Dr. John Higginbottom, dear John, really this work is really his brainchild. So we're very grateful to Dr. Higginbottom for his conception of really developing educational webinars for PSR practitioners and people receiving services and family members and loved ones. And then Regina, that's myself. You know that Advanced Practice is funded by the Ministry of Health to provide leadership, education, and guidance to the mental health field. Really thanks to our instructors for the support and expertise. We have 23 archived high-quality sessions available to you. We hope you use them in clinical practice. They're there for you. They may prompt some discussions. They may offer a chance for a lunchtime conversation instead of maybe a academic paper, but they may, I hope, just provide an opportunity for further education for you. Many of our webinars are not supported financially, so this series does happen to be supported, and we're very grateful to the Ministry for the Advanced Education for their support with this work. Advanced Practice is really, trying to support clinicians, managers, and people receiving services, and those responsible for providing recovery-oriented PSR services. And we hope that you find this work helpful. And just as I say, I acknowledge the support of the Ministry of Advanced Education for this particular project. We're very, very grateful to them for funding, grant funding. This, you'll know, is the second in our second edition of the series. That's hard to say. But today is the evidence-based model of supported employment. On March 18th, we look forward to work integration social enterprises. So work by Dr. Terry Krupa and Dr. Rosemary Lysad from Ontario. We have a great session coming up on law on mental health by a local solicitor, I want to say, which is what we call him in Ireland, but a lawyer. Then we back to Chris Arnold for a session on positive behaviour supports in employment. So please just pay attention to that one. That is an hour later. And then finally, we thought it'd be fun to bring together a group of panelists so that you could chat with them and just have some good question time with them. So it is my great pleasure to introduce you to Catherine, and you will see this beautiful picture, and this is part of Catherine's handiwork here, her good photography skills. But you'll know Catherine, many of you, has worked as a vocational rehabilitation counsellor implementing employment, placement and support model of employment for over 10 years, worked specifically with adults 18 to 64 who are managing mental health issues. Catherine is a member of the Canadian College of Vocational Rehab Professionals and a graduate of Community Rehabilitation Program at the University of Calgary. Catherine also told me today that she did spend some time here at Douglas College learning good things, so I was thrilled to hear that. But she has mentored and trained staff in the IPS model while advocating and presenting at various psychosocial rehabilitation conferences. So I know that Catherine's expertise is appreciated by so many of you in the community. We have dear Lana Cullis. Many of you know Lana as well, I am sure, and Lana does tell me she spent a little time at Douglas College, but she has worked as a change advocate with both individuals and agencies for the last 20 years. She has 11 years specializing in helping persons who have significant life challenges enter and maintain employment. Currently, she's working with the Canadian Mental Health Association, Vancouver branch, to provide one of the one-to-one vocational support to youth aged 18 to 30 on early psychosis intervention teams in Fraser Health. She's a seasoned practitioner of Dartmouth Individual Placement and Support Model, and she has a BA in English and Psychology, a registered rehabilitation professional. She believes that the participant voice is the most vital form of continuing education in mental health field. So we really thank Lana for that. Great. We also want to thank Canadian Mental Health Association because they have been so super supportive of our work. So thanks to them as well. Big shout out to them. Yay, Canadian Mental Health Association. Finally, it is my great pleasure, and Karen will speak with us today. He was born in northern British Columbia, completed high school in Vancouver and University of Burnaby. Karen's completed an engineering degree and a business administration at SFU. He's also completed medical school prerequisites and wrote medical school entrance exam. Same time, he smoked marijuana and became sick. As an All-American and national medalist in swimming, Karen says he enjoys lifting weights, playing rugby, and reading a good book. Currently, he's working for Safeway and hoping to climb the ladder in that organization to work for the IT division. So we're really delighted to have people with great lived experience today and lived experience as well of delivering services. So with that in mind, I am going to pass you over to our first speaker today, Catherine, and I'm going to start the webcam as well. So I'm just going to pop on that little screen there and start our sharing, and then I'm going to pass you over to Catherine.
Hello, everyone. I'm just going to give you an idea of how this next hour and a half is going to go, so you have an idea. Do I just push the return button for the next slide?
Yeah. So this little friend down here.
Okay. Thank you. So we have, as Regina has mentioned, there's 3 of us presenting today. We have Kyron, who will start us off with his personal story. And then I will talk about my role in the IPS supported model of employment as it pertains mostly to early psychosis intervention. And then Lana will talk also about this, although she will bring it from a literature review and provide some stats for you. So first of all, let's welcome Kyron.
So we're just doing a little bit of a shuffle here, and we welcome Karen, who's going to have a little pew here. Welcome.
Hi, good morning, everyone. My name is Kyron. I'm grateful for the opportunity to share my experience with all of you today. I'll start with my personal story, and then I'll talk about, I'll bring in the theme of this topic, which is employment. So I hope to be clear and concise with all of you, and so that you can learn about myself and learn also about employment with respect to psychosis. So to give a bit of background about myself, I was born in Fort Nelson, British Columbia. I went to school in Vancouver and Burnaby, as Regina has said. I was very successful during my mid-20s, or my early 20s, my mid-20s. I was in swimming, university, and I wasn't smoking marijuana at that time, but unfortunately I did start smoking marijuana around the time I was applying for medical schools, and I became quite sick. The marijuana seemed to be a catalyst or perhaps the reason for my psychosis. And so I started hallucinating after I smoked marijuana, also quite delusional. And it got worse as I smoked more marijuana, unfortunately. And the delusions were still there, but then I started hearing voices. So I had numerous symptoms. I had delusions, hearing voices, depression, definitely a lot of symptoms of psychosis and schizophrenia. And unfortunately, I wasn't caught very early. I waited about 2 years before I went to actually go to a hospital. So my symptoms were quite bad by then. However, I did get hooked up with epi, and when I was hooked up with epi, I saw the doctor who had prescribed me. The first drug I started taking was risperidone. Unfortunately, risperidone didn't work. I also tried olanzapine, Seroquel, and stelazine. All these drugs, which are for people who are just having psychosis symptoms, and unfortunately, they did not work. And as I said before, I was already quite severe in my symptoms, so I guess it wasn't expected that the medication would work. So after those medications, I started to take clozapine, which is the drug which is best used for refractory cases or difficult cases. And since I started taking clozapine, which was in December of 2014, I have not gone back to the hospital. That's the big thing for myself, is I haven't been back to the hospital because I was hospitalized many times, 3 or 4 or 5 times before. So since, like I said, since December of 2014, I started taking clozapine, and I haven't been back to the hospital. And fortunately, I've been able to keep a job. So my story with respect to employment is probably the most difficult, because I was very successful, as I mentioned, in my mid-20s and my late 20s with respect to my education, and I wasn't able to get on hold a job while I was having these symptoms. So it was very difficult. Fortunately, as I said, when I started taking clozapine, things got better. But to give my story about employment, why I wasn't able to hold a job is because the symptoms were unbearable. So I would go to work and I'd be suffering these symptoms, and I didn't want people to know about it. That's the first thing, is I didn't want people to know about it, because it would be a stigma, and I feared prejudice. The second thing is, it affected my work. I wasn't able to concentrate. So if I'm hearing these voices and I'm hearing that it's going to get worse, my mind is focused on the symptoms of my illness rather than on the work that needs to be done. So during the last 3 or 4 years, I've held different jobs. I've held easy jobs like being a janitor. I've held more difficult jobs as a computer technician. But all those jobs which I was performing, I wasn't able to keep them because of my illness. So what I guess I'm trying to say is that there is a certain level of perseverance which is required. So not only do you need to stick with the medication, but you also need to persevere with the amount of suffering that you can have. So for myself, in the beginning, I I didn't take the suffering very well in the beginning. But as I've grown older, I've come to cope, and I've learned different coping skills, which allows me to bear the suffering and still perform the work that's required. So I guess part of my presentation that I want to make today is that it's a growing process. So if a person comes into your office and says, "I can't handle work. It's horrible with my symptoms," I would just tell them, I understand you feel quite overwhelmed and unhappy about your current circumstances, but I would say there are people out there who have experienced something very similar to you, and they've succeeded. And perseverance is required. A good network is required of people. And that's what I wanted to share. The key point I wanted to share today was that perseverance and teamwork with your family, with your friends, is required. And those two facets will allow you to keep a job, hopefully. Everybody's different, of course, but I think for most people who I've talked to, is that those two facets, teamwork and perseverance, are very, very important. I guess I'll finish up my personal story with, I guess, a good note. I had an interview yesterday, and I was given an offer for next week that it is a job which involves my engineering. which is a huge difference between what I was doing 3 years ago, working as a janitor, and now I'm working. When I start working as an engineer, then I'll finally use my education, and I feel I've persevered, and I feel quite content and happy and satisfied. And I just wanted to just end the story with: don't give up, persevere, and you know, it's it's a strange life, but at the end of the day, there's always an answer, and I believe there's always success around the corner if you persevere. So, if there's any questions out there, I would love to hear your questions, and I hope to hear them after Regina facilitates for us.
So thank you so much, Karen, for that glimpse into, I can't even imagine finishing engineering school, never mind trying to live a life with significant mental health symptoms and trying to manage medications. And that's so, I think, empowering for others to hear in terms of the journey, and insightful in terms of those of us trying to provide services. Your message about persevering is really an important one, and I think your voice may help others be able to understand what that's like. I'm just going to check in and see if we have some questions. Sandra says, I echo, wonderful recovery story. You deserve to be proud. Good for you. Thank you for your courage to share. James says, thank you for the wisdom of your insight and experience, brave Kyron. James, you're always so eloquent. Thank you kindly for that. Doug says, Kyron, what support did you get from your employment counselor that helped most? I'm not sure if you have some things to add. I know those of us who are deliver service sometimes, we always like to know what might some of those magic bullets be. Thanks for that question, Doug.
Hi, Doug. To be honest, the EPI team has been quite helpful. However, the job I currently have was obtained through using Work BC, but as I understand it, EPI does provide assistance with work. I imagine it's quite helpful because while suffering psychosis, you tend to become very isolated, and EPI really pushes you to not to be isolated and to get out in the community and try to rehabilitate yourself. So, like I said, I didn't use EPI for a job procurement, but I do understand they do help with other people. So, what support did you get from your employment counselor that helped the most? I would just say the check-ins with my clinician was very helpful as well. So it's all about for me, with respect to getting a job. It's about encouragement. It's about perseverance, and EPI has been very useful that way. So.
Thank you, Susan, for your comment, your kind comment. Karen, thank you for sharing very valuable perspective. Shannon adds, and feel free, Karen, to offer us what you feel safe in terms of a response to this. But the question was, is there a history of mental illness in your family, or do you attribute your experience maybe to smoking marijuana?
Okay. Yeah, I just wanted to put this in. While I'm having these discussions with you, it's very hard for me to think the top of my head. I still suffer from schizophrenia, and it hinders my ability to think. But if I understand your question, you're asking what was the reason for my psychosis. And as far as I know, right after I started smoking marijuana, I got actually the marijuana from a bad source. But after I started smoking marijuana from that source, the symptoms were like that. It was really quick. So I guess I don't know for sure that was marijuana, but it's pretty highly correlated in the medical literature as well as my own experience. So there's no family of mental illness in my family. There's no history of mental illness in my family. As far as I know, I'm the first one in my family to suffer from schizophrenia or psychosis. So.
Thank you for that. Thank you for that generous response. And my sense is that you're thinking extremely well to come into a new environment and be put on the spot and answer some questions. I think you're doing really, really well. But I do appreciate Shannon's question in terms of, just as a clinician, just trying to tease out sometimes, how can we support people with multiple barriers in terms of just substance use, perhaps it's marijuana, or, the mental health issues, and just any maybe kernels that you might have for us in terms of just working with people who have some of those issues, just to help us maybe think about doing a really good job.
Yeah, so Gail Steffen asked, what additional help would you appreciate regarding support with your employment? That's a question which I think isn't relevant to myself any longer, because I do feel I've conquered my illness while at work. Fortunately, I don't need to leave work, and like I did 3 years ago, I had many shifts where I had to leave work because the symptoms became unbearable. But at the moment, I'm able to bear through most of my symptoms without having to leave work. So additional support isn't necessary for at the moment, but I understand there are programs in place which allow for a person suffering from psychosis to travel to a job site with their clinician or their help, and they're able to facilitate a discussion between the person suffering from psychosis, the employer, and the clinician. And that dialogue allows for there to be some honesty as well as some discussion of support. So for other people, I understand there are those resources available. So thank you, Gail Steffen, for your question.
And Shannon just adds, thank you, appreciate very much, wonderful to have and share your experience with us. Thank you, Shannon. Yeah, so I think maybe we'll just we'll take this last question and then we'll just pass it over to Catherine again. And the question is, how has your interaction been with your employees?
Okay, well, I can answer. Yeah. I can hit two birds with one stone here. Conan asked how your interaction has been with your employers, and Gail asked, you mentioned the stigmatization that many people suffer. That's probably the big thing is, if you're employed by someone, most of the time I think people are very cautious with respect to telling their employer about their illness. I don't have a problem with it. However, I don't think it's necessary. I still believe there is some stigmatization because mental health isn't well understood. Like I remember before I got sick, I didn't have much of an idea of what mental illness is. So I can expect other people to have a similar understanding and knowledge of schizophrenia and psychosis. So, if they hear it, they probably won't go research it. So their understanding of your illness and the stigma which is there won't change because most people I've met don't research it. So my interaction with my employers that way has been very, very tame. So I haven't been, unless I've been asked specifically what is your health condition, and I haven't disclosed it.
So thank you, Karen. That's really really helpful. Appreciate it. We're going to pass back to Catherine. Thank you so much. Karen will be in the room, so if there are other questions, I'm sure we can maybe bring them back at the end of the presentation. So thank you kindly.
I just wanted to say in a final note, thank you for joining this event. Like I said, people, I believe Canadians, especially Canadians who try to foster understanding with respect to multiculturalism, mental health, and other issues, are quite proactive with that. And I think it's important to be proactive because if we want to foster a society of understanding, then I believe researching and joining seminars like this are necessary, because otherwise you just won't ever learn, and people who are suffering mental illnesses will feel more isolated about their condition, which isn't helpful at all. And I think I thank you again for tuning into the webinar. Thanks.
Such an eloquent response. Thank you very much. I really appreciate that. Just wanted, before I pass it over, just to say, very nice to see somebody called Conan in the audience. We have a son called Conan, same spelling, so we rarely meet somebody with that name. So I just want to say that was really cool on the side. And that's just a segue back to Catherine.
Okay, hi everyone. Kyron, thank you so much. I think that what's going to happen, I don't know about you, but when I leave today, what I'll remember is his story, and I think that's what's most important. Kyron's comment about smoking marijuana and getting a bad source is a really interesting one. It's something I would like to know more about, and I think we all would, in terms of psychosis. However, at the end of the day, Kyron was speaking about this is what the cards I was dealt with, and this is what I had to do. The word perseverance came up a lot in Kyron's presentation, and I think it's important for us as practitioners to also remember our perseverance, because sometimes we may feel downcast or feel that things aren't moving forward. It's very important not to freeze people in time, ourselves and those that we are supporting. So always keep that in mind. It's a very, very important thing. And I think that Kyron's comments today tell us that his life is going on. We don't know where he will be. He doesn't know where he'll be in the next 3 years, but things are carrying on, and life goes on, the good, bad, and the ugly. And we're all here to share. And thank you for the celebration.
Next. Not doing my job here, not advancing slides. Oh dear, I'm going to get fired. Go.
Okay, so for those of you that were in my webinar last year, I spoke about IPS, the Individual Placement and Support Model, in general. I'm just going to review that because even though we're speaking specifically about EPI or people that have accessed, who are accessing early psychosis intervention programs, this is the overarching definition of what IPS is. So according to Bond, IPS support employment helps people with serious mental illness work at regular jobs, those paying at least minimum wage and of their preferences. And there are many variations on the theme. IPS does have a lot of evidence base and research behind it. It's the most robustly researched model of its kind. Yeah. So, okay, so here's the EPI program. This is a collaboration between Fraser Health and the CMHA Vancouver Fraser branch. And Lana, who you will listen to next, she and I are involved with others regarding the occupational recovery project research after first episode psychosis. And just for your information, if you want to know more, the principal investigator is David Erickson, who is a clinical psychologist with the Fraser Health region. Okay, so what's this all about? Basically, we have 100 clients that we will see. Sorry, that's not true. 100 clients will be randomly chosen, randomly assigned to the IPS model or treatment as usual. Treatment as usual could be another employment program. Kyron just mentioned Work BC, or there may be nothing at all, depending on or very little, according to the community that those people live in. So this is over a 3-year period. And again, it's a collaboration, not just with Fraser Health and CMHA, but the Federal Ministry of Social Development and Social Innovation. So this program started, the research started March, April of 2015, and it began with the North region of early psychosis intervention programs within Fraser Health, specifically Burnaby, the Tri-Cities, Maple Ridge, and New West. And then it extended now into Surrey, Langley, and Delta. And as of December 1st, it is extended to Abbotsford, Chilliwack, and Mission in the Valley area. And those people that we do meet are between the ages of 18 and 30 years old. Okay, so why are we doing this at all? What's this all about? There's a critical time when individuals who are dealing with a psychotic break cross over to what's happening now? What am I going to be doing now? So according to what we're looking at, we're hoping that we can help people choose or adapt interventions according to the individual predictive factors and their cost benefits. So by helping people with their employment success during this time, hopefully we can prevent longer-term decline and avoid use of health services and disability benefits. And for those folks living in this situation, it gives them the opportunity to have an integral lifestyle rather than living on the periphery of their community. So first of all, let's look at the past a little bit of IPS as a practice of supported employment. It's been around for 20 years, and it started specifically in New Hampshire when clinicians or employment counselors were seeing that individuals were involved in pre-employment programs, sometimes for great lengths of time, but they weren't going forward and actually working, or they may be working in a very minimal setting or in a very protective environment that anyone might not apply for. So now IPS is here in Canada, in certain spots across the nation, and also in Europe, specifically the Netherlands and Norway, Australia, Hong Kong, and the UK itself. So it really looks at a shift in thinking about psychosocial rehab from what has been traditional pre-employment to and away from a sheltered workshop situation. And the recovery movement in general is helping to continue and instigate true inclusion responsibility to one's community. In other words, it's not just about being part of a community, but also participating and giving back to the community that people live in, a sense of citizenship, if you will. So where are we now with the IPS model? In general, we stay very close to fidelity. As we talk about marriage fidelity, for example, if we drift away from fidelity, then we don't have the integrity of that relationship anymore. So in the IPS model, we have a very formalized fidelity scale that we stick with. It's developed by Dartmouth in New Hampshire. And these are particular principles and that we are applying very specifically to this research that's happening right now. And according to Drake, as of 2014, those individuals accessing EPI programs who have also accessed IPS programs, the employment success outcome is 82%, pretty darn good. The benchmark for IPS employment success overall is at 50%. Now, according to Work BC, their success rate for all user groups, and by all user groups, I mean any individual that walks in the door asking for help with employment. They may be people with disabilities, they may not, and any and all kinds of people that come in for support regarding employment. So the work placement rate is, according to Work BC, 42% at this particular time, and that's of 2015. No kidding. So what's going to happen to the future? Where are we going to go? What we'd like to see, what CMHA would like to see, is that IPS as a model of supported employment, and I think Kyron touched on this briefly. We would like to see that this particular model as an integral part of a particular. We're having some problems here.
Just hearing.
Oh, okay. Let's come a little closer. Okay, I'm being told I got to be closer. So what we'd like to say is that thank you, Regina. So we'd like to see this particular model as a standard part of recovery for these individuals accessing EPI. And we'd like to see outcomes with research continue on to see where we could do things better and where we can do things differently in regards to the economy, the social and mental welfare of those individuals involved. Just so you know, there is a national IPS project, and we won't speak about that today, but if you are interested in knowing more about that, you can contact the CMHA Vancouver Fraser branch to learn more. We'd also like to see, according to Eric Latimer, in 2015, the emerging practice or promising practice of cognitive remediation is happening as well, or we'd like to see more of that. So something to think about, there is a tension where IPS is offered to people who are attached to care that has case management. And this is indeed a pivotal principle of our model and positive outcomes. What about those people who do not access case management and may have a mental illness? What about those individuals who are not necessarily as ill as some of the people we work with, but they need help going back to work? Where does IPS fit in that? And if it does, where would it be? According to Dartmouth, this particular model is now being researched to look at those other groups of people. For example, this is something that's going to be Lana. But just so you know, for the future, they are looking at other groups of people, for example, those individuals with PTSD, people with addictions, and so forth, that may benefit from the IPS model, but where the case management may not be integral to their care. So that's something to think about. So for now, what I'd like to do is introduce you to my colleague, Lana Cullis, who will talk more about EPI and very specifically about some of the work that's happening. We have a question.
So maybe just before we do that, Liz, thanks for your patience. You were asking, do these success rates factor in job maintenance, or is this initial job placements only? We're hoping you can hear us. I'm not sure that you can, but if a couple of people could just text, let us know. If that's good, please let us know. But in the meantime, maybe you can just maybe address that question. Thank you.
Okay, so according to the fidelity of the IPS supported model, the job that an individual would get, the success is measured that they actually got the job and they actually did the job. And it would be a job that any one of us might apply for. It wouldn't be one that is in a protective model. It may be a job that isn't necessarily sustained very long, because sometimes, particularly with EPI clients or a young group of people, as in general, people often move from one job to another until they land it. But we do measure that success, and we do support the person while they're there, before, during, and after. And now I'm going to pass you on to Lana, and if you have more questions for me or any one of us, we'd be happy to address them at the end. Thank you.
So welcome, Lana. Thank you very much. You want to do the slides or want me to?
Oh, I'll get you to do them.
Okay, no problem.
No, these are mine.
Super. So we're just having the good old shuffle. You know how it is. Just getting settled, and off we go.
So just to, first of all, good morning, and a special shout out to all those people that are dialing in from the northern parts. I'm also from northern BC, and we were talking about that this morning. So hello, and hello Smithers, if there's anybody up there from Smithers. And just to dovetail on what Catherine was saying and that question about the stats, we do in IPS programs keep track of people who work for 3 months or more. Now I don't have those numbers on my fingertips, but we do value and help people sustain jobs and support people to keep their jobs. That's a very important part of what we do. But in terms of the stats that we're quoting today, and that you'll see some of those stats in the work that I'm about to present as well, those figures are going to be related to job search and those initial jobs, actually just getting jobs. So I just wanted to make that distinction. So first we're first things first, let's speak about persons with psychosis in general who work. And so, in preparing for today, I did a rather large literature review. And so I'm not going to be reading out everything that's on the slides, but highlighting some of the things that are on the slides. And so I'll get you to read along. So on this slide here, one of the things that I wanted to highlight was the stat about restraints. So there's a pretty big discrepancy between the 14% of people who are employed, and when they go into a hospital, that's a fairly low number who might end up in one form of restraint, either chemically, physically, or using seclusion rooms, compared to persons with mental illness, 64.5% who are unemployed. So what is that protective factor? And so some of the things that come into play might be attributed to the social skills that persons that are employed get an extra ability to master through working. So things like dealing with authority, dealing with conflict in the workplace, and that ability to manage stressful situations, and that ability not only to manage other people in their workplace, but to self-manage themselves. And there's things like ability to read others in a social context that gets reinforced day after day going to work, and especially over time. And the ability, and this ability yields that transferable skill that happens in work, and especially persons that have worked in one workplace and then transferred that maybe to another job place and another job place that gets reinforced over time. So in one way, you have that stat and it looks like a simple number, but when you really start to look at that and really uncover what is there from a person being employed and what that brings them to the rest of their health situation, it's really significant. The other thing that I wanted to highlight from this slide was the stat that notes higher medication compliance. So when you're an IPS worker, you work on mental health teams, and sometimes what comes up is a little bit of fear or concern from mental health team members to refer persons to your program, because they are concerned that perhaps if people work too soon or too early or in certain situations, that might compromise their compliance to the treatment plan. And when we look at the medical literature, when we look at the reviews about people that actually are working, what we see is actually a higher compliance to the treatment plan. And some of the reasons that are given for this is that when people are working, they are more invested in their wellness because they need to stay well to keep their job. And not only do they want to stay well to keep their job, but they want their job for other things in their life, to pay for their housing or to maintain their social network through work, these kinds of things. So that's a really important thing to be able to know as a rehab professional and to be able to share that message with care teams. Next slide, please. So, I'm new to doing the webinar, so I'm just going to let all of you know that, but I'm learning about how this works.
You're doing really well. It's all good. Okay.
Okay, so this one's here. Okay, so research. Okay, so what I want to highlight on this slide is this number: 78% of youth with psychosis want help to find work. And that is a huge number. And so what that really means is that the people that we're working with come primed already. Basically, we just need to not get in their way. There isn't very many places in healthcare where people come this committed to the solution before we even see them. And so that's really, really, really exciting. The other thing that I wanted to highlight about this is that the risk of suicide is also known to be a lot higher in this population, and it is a real risk. But the thing that we know with statistics around suicide are that there are some very real, also studied protective factors. and they come from the field of PSR. And so 3 of them are work, school, and social connectedness. And social connectedness and work, of course, overlap. So the work that we do as rehab professionals in helping people get connected to jobs is one way to address the suicide risk. And this is something that myself, I have had a number of individuals be identified as having a risk for suicide or have conveyed suicide ideation. And one of the things that has really decreased that and has helped people move forward with their life is when they have become attached to jobs that they like and that they've chosen. And that's something that I can't underscore enough. And the other thing that comes up in suicide literature, prevention literature, and trainings that you'll go to is that having purpose and meaning in one's life. And many, many people identify that through work. And so again, it's another option that we have as rehab professionals to connect people to that sense of meaning in their lives. And motivational dialogue, those skills that we get through that, is a way to help uncover that in the process that we work through. Slide. Oh, no, not quite. Let's go back one. So connected from this is the importance of building hope with tangible supports for the persons that we work with. And so some of IPS model has, and you will have, if you tuned into Catherine's basic webinar on the IPS model, she will have gone through the 8 principles of IPS and then also the values, the 6 values that are in the IPS model. But some of them are things like no wait list. So you can imagine if 78% of youth are coming in already wanting to work, how helpful would it be to have large wait lists? Not at all. So one of the values is to not have a wait list. So they're identifying they want to work, then we get them going right away. And that's one of the values. One-step reintake. So imagine you have a youth, they're working, something falls apart with the job, and then they want to come see you again. So instant reintake. And with IPS, we prioritize persons that are re-entering the program over new entries if we have to make a choice. If there's a... Oh, sorry.
We're leaning in for clarity of sound.
Okay, sorry. Okay. See, new learning for me too, learning on the job. So, okay. And another value that we have is continuous time unlimited support. So earlier we were speaking to that stat about 3 months. With IPS, we have a continuous support for as long as it takes. So although it is rare, we may have somebody on our caseload for up to 2 years. 1 year sometimes is common for providing on-the-job support. With EPI clients are in a 2-year time-limited program. So with EPI, that support would only last for 2 years. But what becomes really important with EPI is for practitioners to be involved in the transition and doing that case planning with case managers and physicians and occupational therapists, if they're on the teams, to help EPI people when they're transitioning from the team into the community to say, hey, what kind of support would you like after you're finished with the EPI team around work? Can I bring you to the Work BC office? Can I help introduce you to the people there? You know what? They're really great. Like, let's get that started before you leave. Let's make sure that that happens. And be involved in making sure that that continuous support happens. That's one of the principles that we do. And I like to think of this as a visible scaffolding, that the IPS worker is like a scaffolding on a construction site. Slide, please. And I love this slide. And I love this metaphor, and I thought of it. I'm going to take full credit for it. So you think of any kind of construction site, whether it's a new build, an old build, the Taj Mahal, getting new windows, whatever that looks like. You can see that scaffolding on the outside. It's real, it's strong, it holds up the work that needs to be done. And I don't know if you've ever seen a scaffolding crew working, but they put that scaffolding up really quick. The work gets done, and when it's over, it comes down again. And the scaffolding isn't perfect, isn't permanent, but it's there to help with the work that needs to be done. And what is permanent is the structure that's underneath. And I think in the past, what has happened, and Catherine mentioned this in her talk, about where employment supports were in the past with sheltered workshops. The workshop was permanent, and clients or individuals would go to the workshop day after day after day, and the workshop was more important than the persons that went to it. All the money was invested in the workshop and the building and the staff and everything. And I think that there was a time for that, and there was a lot of love and community that was created in those places, but at the end of the day, the people had no other place to be but those places. And what I like about the scaffolding metaphor is that it can go up and down, it's real and it's firm and people can count on it, but it's temporary and it's transitional, and what's most important is the structure behind it, which is the person that you're working with. So that's how I think of IPS, and that's something that you can think about and take with you, discard or use as you find useful. And it doesn't just have to be IPS. It can be any of you that are working in communities doing the kinds of things that you do to be helpful in your rehab practices with persons. Next slide, please. Okay, can we, yeah. Yeah, no, you're beautiful. Thank you for your help with this. I was kind of worried about
you're doing a great job
because I get distracted with things. That's part of how my brain works, but this is good. Okay, so let's talk now about substance use and psychosis and youth, this triangle. Let's bring these three things together, and let's talk about how the IPS model can really be key when we bring in substance use as well to this. So IPS has a zero exclusion principle. And zero means zero exclusion. And so what we mean by that is all a youth needs to do is say, I want to work, and then they're going to be helped. So with substance use, what that means is if a person is still using a lot, using a little, trying to decrease, doesn't matter. They're going to be helped to find work. And so that's it. And what that means in a treatment situation with case managers and everything is that doctors may sometimes say, oh, well, they're using too much, they shouldn't be working. And what IPS workers do in that situation is really advocate for the client in that situation. And with newer teams that aren't used to the IPS model and they're getting used to that, that can take a time to educate a team around the IPS model. But the ideal, the fidelity, that we want to employ and work towards is that the client voice is the most important voice, and that their use is not a barrier to their receiving treatment. And having said that, sometimes what comes up at this point is this idea of that we're only harm reduction and that we're against abstinence. No, that's not what I'm saying. The individual's treatment plan, their own treatment plan, that is always taken into account. But what we're saying is that there is no exclusionary factors based on their disability, their mental health diagnosis, their addiction factors, their housing, whatever, nothing. Okay, and then the other thing that I'd like to comment on this slide is that the IPS is working towards building tolerance to adverse work experiences. So sometimes what happens in employment programs is that there's a lot of focus on success and getting that first job and holding on to that job, and then we count our stats and everything is wonderful, and that's not what we're about. What we're about is helping that person develop skills that are going to see them through over time. So if anything, we really de-emphasize that first job. It's like, okay, well, this job might work out, it might not. You might like it, you could hate it. Your coworkers could be really like just not a good fit for you. How are you going to know if you like this job? You could quit the first hour if you want to. You don't have to stay there. You know, like the location could suck. We really do a lot of work on de-emphasizing the importance of any one job and building the person's capacity to make distinctions about how to make an employment situation work for them and their health and their substance use, and how that's all going to come together, and to build their tolerance to adverse work experiences. And so one thing some of us say is we like to get them to apply for and be declined for a job right away, so they have that experience right away of not getting a job, being turned down right away, and what that feels like, and moving past it right away. And so these are some of the things that that we want to have a person have. And if you have addictions going on, sometimes addictions come from a way of dealing with stress, and it's a go-to for that. So if we can start building in mini experiences where people work through that with your support and have that support right in the session to do that, then they find that that's a very safe place to have negative experiences. And work is like any other negative experience, and it's destigmatized, and that tolerance grows, and that can be a very helpful way to deal with things. Slide. Again, getting further into the substance use aspect, what we want to be really highly aware of is that substance use profiles are really different with different drugs. So here's where you really want to educate yourself on what the pharmacological effects of different drugs are. So, for instance, marijuana has a really different pharmacological effect from crystal meth and from cocaine. So if you're working with a person and their primary drug of choice is marijuana, this often slows responses. And so they may be a little more, and it sounds stereotypical, but laid back when they're using. And those effects can last in between uses and can affect motivation. Not always, though. So you want to be really open and listening to what your person is saying to you. Whereas if you're working with a person whose primary drug of choice is crystal meth, that can have an effect with the person that can make them quite unpredictable and impulsive, and can affect their judgment. So if you look at this occupationally, we really don't like to see people who are using crystal meth being as a traffic control person, for example. And that's just not a good match, right? So that's one way that you want to be using your knowledge about pharmacology. But another way that you want to be keeping these things in mind is that there's the illicit drug use, but then you also want to be aware of what prescription drugs that people are taking, and what the intersections between those drugs are and how they're using them. So some people are very religious about when they're taking their prescription drugs, but then they're also using illicit drugs. And do they have consistent habits with their prescription drugs? Because if they're consistent, that's one way that it means one thing for planning with jobs. But if they're very unpredictable in their profile with how they're using their illicit drugs, then that can be a little bit more difficult when you're planning to try and find jobs, and with their appointment attendance and things like this. So you want to have as much information as you can on the table with persons, and you also want to know about safety things and this kind of thing, and where these drug uses might interact with each other. Now, having said all of that, then you want to be taking into account the labor market, and you want to be sharing with your individual the real dynamics of the labor market. So one of the really important things about IPS is that We don't go to the labor market and say, oh, there's 40 positions down at the GM plant that have just opened up, and you can go work there. We look at what individual preferences are and then really advocate and help follow through with that person with whatever their job goals are and help them try and find that in the market. But on the other hand, if you have a person that's a poly drug user and is really quite ill and having a lot of symptoms, and they're wanting to do something that is quite, for all intents and purposes, unrealistic in the job market, how do we bring these things together? So one of the things that we do is provide a lot of information and work side by side with the individual to help them discover that information. So we maybe might bring them to do informational interviews firsthand. We might show them the jobs on the internet together. Don't just do the research before they come in and give them the job postings. Do it together. If they ask you your opinion, give it to them. You've been doing this for years. Share it with them in a very open way. Tell them what you're basing your opinion on. But at the same time, if they keep expressing the same goal, work towards it. But when they come up against barriers, be really clear about why those barriers might be there, and then express what things could be changed and ask them, and always give a lot of choices. And if you can think of things that might make the difference, present that to them, and always be offering a next step if you can see one. Always keep trying to move forward, given the variables that they're giving you. I hope I'm making sense. So one thing that I say is, given your current choices to keep using this substance on Tuesdays, Fridays, Saturdays, and Sundays, those are your big party days. So we only have Wednesdays and Thursdays left that you can work. And given that this is the job that you're interested in, and you don't want to work in this community, and this community, this is what's available to you. What do you think about that? And then go from there, that kind of thing. Next slide, please. So it becomes really important to do what we call, which is continuous assessment. We don't do formal assessments in IPS, but we do a lot of continuous assessment. Is this working? Is the person continuing to move forward? Are they showing up for appointments? Are they doing homework? We try to give a lot of homework, give as much agency to the person as possible. Are they doing more? Are they going further into their addiction, or are they kind of holding back more and seem more engaged in their job search? Reaching out to their treatment team. What does their treatment teams see? Family members, is their family involved? So really trying to check in and see if what you're doing working. And if anything is working, lean further into that and go with what's working. Another thing is to be willing to stop jobs. One thing that comes up with addictions that I've noticed, and I don't know, part of me hesitated bringing this up because it can fuel a fear that people have, but I'm going to mention it anyway. Sometimes when people with addictions do start working, it can create more stress and it can start the addiction going. And it doesn't happen as much as what people think it does. Usually when people start working, things get better in people's lives. But for the few people where that does start to happen, listen to your client. And if that's what's happening, support them to quit the job with dignity. And so what I mean by that is, how can you quit a job? How much notice do they need to give? Who should they talk to? How much should they disclose? Can they take a break instead of quitting? Can you go to the job with them and lend your authority to give the employer a sense that maybe what's going on is health related rather than character related? Mm-hmm. How can you support the person? Is it that they need a break from something else in their life? Because sometimes what people think is that it's the job, but maybe it might be that there's something going on with their family, or the team is stressing them out, or other things. How can you create a space to fully look at everything that's going on and then help them proceed in a way that's thoughtful and smart for the situation, and doesn't just focus on the addiction, because the addiction is often a go-to place. It's a shortcut, and sometimes work is sacrificed. And if it really is work, then great, get rid of that job and help them do that, but do it with dignity and do it in a thoughtful way. Be willing to support the client to utilize other services, refer out and welcome back. So this is a big one. I know I'm here today representing IPS, and I come across with a lot of passion, and I do think we are the best. But having said that, lots of times people need something else. They might need an OT. They might need a recreational therapist. They might need to go to the clubhouse and have social connections, and that might be more important. They might need to spend time with their family. They might need Work BC, and Work BC has some really amazing things, like the classes that they do, like the dropping in every day and using the computer and that constant connectedness that they offer. And they also have the destigmatizing thing where it's a non-mental health service. So sometimes, especially with youth, connect them there if that seems like an appropriate step rather than using our service. So refer out, and then if they want to come back, take them back right away. So be willing to support your client. If they're expressing a need that they need something else, then support that right away. And that helps people to flourish. And that can have really good ramifications for their overall recovery, not just their employment recovery. And then finally, what I want to say is about this is to practice moment by moment engagement and not plan engagement. And what I mean by that is many times as workers, we get so focused on this great plan, and we're going to draw in, our partner over here with this agency or this employer that we've had in our back pocket for 3 years, and finally we get like an engineer like Kyron that we can place here, and then the next day our person comes in and they're like, no, I don't want to do that anymore, and we're like, no, and we get so attached to the plan, and we guilt our person into working that, and then that guilt or our energy or our agenda supersedes what's in our person's best interest. And with addictions, I think this is really important, because persons with addictions often are very, very sensitive to this kind of energy, and that can cause use and increased use. And I think what's really important is to practice that moment by moment engagement. Whatever they come in through the door, that's what we work on, and that is what's really helpful with the person. The plan is not important. The person is what's important. Slide. So in summary, and again back to the literature review, overwhelming with everything that I read through the EPI research, early psychosis intervention research, and the research that I was doing with substance use and youth, and where these things came together. This paragraph kind of summed it up. It said, addressing substance use disorders and social and occupational goals in people with first episode psychosis may offer opportunities to prevent substance use disorders becoming more severe or entrenched. Now that was from Ribagetz et al. In 2014, and that was more recent research. So what's important there is that if we do the work around supporting our youth to get involved in jobs that are of their choosing and jobs that they are excited about, work that suits them, that is actually going to have the impact of stopping their addictions from becoming more severe and from becoming entrenched. And that is really exciting news. The work that we do actually can change the course of their addiction. And this was replicated over and over again in studies that I was reading. And I listed a fair number of them on the back if you're curious to do more reading. And the other thing that I really wanted to highlight is that some work by Miles Rinaldi et al. In 2008, and this is a British study. And it says that the indicators that do appear to be robust predictors of work outcomes include recent employment history, motivation, and self-efficacy. Wanting to work and believing that you can are the best predictors of work outcomes. So for me, what stood out there was, one, the work outcomes of recent employment history. So that work is reinforcing. So if somebody has worked, that in itself predicts future success at work. So that thing that I was talking about earlier about vocational maturity, each time we help a person get a job, even if it doesn't last very long, that's going to help them again become more successful. And so, you know, these youth that are coming in already wanting to work, and they want help to find work, each time that we help them just get a little bit further along, that is predictive of their success. And that the diagnosis, the addiction, what other people think, whether they can or whatever, is not what's relevant in their success. What's relevant is that they want to work and that they believe that they can work. That's the best predictor of work outcome. And how liberating and how freeing is that? That the desire to work is what can predict if you can. There is nothing that can stop these young people from being successful. And so with EPI youth with substance use challenges, even those who identify as at risk for suicide, they have a very good chance to make their recovery by working. And we know that the best practice model to obtain employment is individual placement and support. And for those working with youth, the exciting news is that 78% identify as wanting to have help to find their place in the workforce, even before we meet them. And we only need to come alongside and vigorously support their belief in themselves. And so that's it for my part of the presentation, and Regina is going to help guide us through some question and answers for all three of us. And thank you for your time and attention.
So thank you very much. I think the thing that sort of sits with me is vigorously support people around us. That's such a nice way to think about things, and you gave us so much to think about there. I really, really appreciate that presentation. You clearly did lots of homework, as you said, so thank you kindly. May we please start with the first question, and that was, in terms of thinking about somebody who might be using marijuana, what happens, if I understand the question, if that drug is maybe cut with something else unknown to the user? How do we work with that?
Well, that's actually a more general question than probably what the person thinks. That would be based on the effects what the functional effects of what you're seeing with the person. So, so how is that affecting the person's behavior or the person's ability to think? Are they having cognitive challenges? Are they, so I guess for me, I would address that. What is the person expressing as distress from that? So is the person expressing challenges with memory, or is the person expressing a delusional thinking system? Maybe the person has no effects. So for me, it always comes down to what the person is thinking or expressing as a expressed need.
Thanks for that. I think Karen wants to add a little something to that, so we'll just give him a minute to shuffle over here. And thanks very much for keeping your questions coming. I will do my utmost to just scroll up and down and make sure that we're answering. So, Karen, welcome back. Great that you have some things to offer. Thank you.
Okay. When I was sharing my personal story, I told you about the source of my marijuana. So I understand the source of my marijuana wasn't a very good one. So if I don't know what I was buying, then I could have been smoking something that was laced with a chemical which doesn't give you the kind of high that you want, and may have detrimental effects in the future. So my advice or my belief is that the clinician should advocate the user or the client to search for a better source. So the clinician won't tell them to stop. The clinician will ask them, are they finding a safe source? So you don't need to judge the person. You just the person's finding a safe source. It's similar to cutting. If I worked at a crisis intervention center, and the question we were supposed to ask was, are you cutting yourself with a clean knife? Is it this? Is it that? So you're not judging them. You're just asking, are they keeping it safe? So same with marijuana. I feel buying from a well-known source is the best. Going to a dispensary, you're not judging the person. You're just asking them, are they keeping it safe?
Cool, Karen. So I think a good harm reduction, perhaps, approach.
Yeah.
Thank you. Liz asks, what about a job situation where the reactivation of the addiction may pose risks to others in the workplace? Do you ever find yourself having to do more than counsel the person to leave the job with dignity? I'm thinking about people who may be working on the social services, whose addiction may put people they support at risk. I think you're going to take that, Lan, are you?
Yeah, I'm just thinking about that.
Yes.
Yes. So your question is that the person using at their job site might put the other people at the job site at risk?
Mm-hmm. Sounds like.
So I'm just trying to think of what that would look like. So, I just had what went through my mind is like if a bus driver was drinking on the job, and the drinking and driving would cause harm. So we have ethics a code of ethics that we have to operate by. And so in the case of drinking and driving on the job, if it's going to cause imminent harm, that is something that we would bring to our supervisor, first of all. And that is something that we would bring to the team, and we would have a discussion around that in terms of around the code of ethics and trying to work through what the safety issues are around there. And if in fact it was a safety issue, we would be really clear with the person that we're working with around the fact that a safety issue. So in case of the drinking and driving and the bus driving, and so. First of all, we would really work very, very hard to activate the person's sense of responsibility in that. And so myself, and speaking only for myself here, I would work really hard to support that person to remove themselves from the situation, at least temporarily, in order to deal with that situation. If it became evident, if you want to go to worst case scenario, that the person was not going to do that, then myself as a professional, and if other people were truly in danger in that situation, then I would, with knowledge of the person, then I would tell the person what I would need to do as next steps, and make sure that the person was aware of what I was doing in order to preserve the safety. In my experience, I've never had to do that. And I've been doing this work for, specifically this kind of work, for 11 years. Mm-hmm. And 5 of those years were in the downtown east side with people with severe substance abuse issues. My experience is that most people have a lot of dignity and a lot of care for other persons, no matter how far advanced their addictions are. So I think, though, that many of us as practitioners, we do worry for our persons that we serve. And we worry about what if and what might happen, but most of those scenarios don't come to bear.
Lana, that is a super comprehensive answer. Thank you very much. You've brought us back to our professional ethics and to really help that guide our behavior, and I really appreciate that. Sometimes when I talk to clinicians, they worry too about sometimes how that behavior may trigger others. So they see somebody maybe in the workplace and maybe there's some usage, and they worry, I think, sometimes what is the role in terms of how that behavior might be triggering others. I don't know if you have wisdom, or if others in the room have wisdom. Maybe Karen.
About like, I think our, and again, this is only my opinion, but I think that we're responsible for the person that we're directly working with, and other people are responsible for their own recovery. And I think even in the AA models that is a sentiment that is taught around, that you're responsible for your own recovery. Mm-hmm. So there's a trust that that people who are on their own journeys of recovery are responsible for their own journeys of recovery. So as a practitioner, my understanding, and again, this is a discussion, mm-hmm. my understanding is that I'm responsible for the person for whom I'm working with
directly.
Mm-hmm. And there's imminent harm of, like the bus driver example, absolutely. Where people's lives are at risk.
Yeah.
That is a different ethical discussion than my person who's using, and somebody might know they're using, and that might trigger somebody. Right. I don't believe that I'm responsible for what other people might see mm-hmm. and be triggered by.
Mm-hmm. Thank you, kindly. I'm nodding. I'm looking for nodding rooms, heads around the room. Samantha asked, and maybe this is our last question because we're at 11:51. Maybe we can squeeze one more in if it just comes in quickly. But Samantha asks, is there disclosure to the employer with substance abuse? And what is the impact if somebody has a relapse at work? Can they have the potential to lose their job? We live in a small community, and I've always worried about, burning our bridges.
Yeah.
Good question.
That is a super good question. So the IPS model is very clear that disclosure is the person's choice. And that is true with mental health issues and also with substance abuse issues. So the short answer is that no, there's no disclosure to the employer unless the client or the employee wants to disclose. Having said that, sometimes there's disclosure after the fact if there's been an incident happen at work, and you have to go back and sometimes do a little bit of damage control, or work with the employer to have the employee come back to work and work on that. Mm-hmm. Yes, small towns can be difficult because everybody knows everybody mm-hmm. and knows what's happened. So in that case, where a vocational counselor can be really helpful is to go with the client and to work on some kind of work contract around that's based on performance or behavior, like like a probationary period or something where that's based not on rumor and innuendo, but based on, okay, this is my job description, and I'm coming back, and I really, we want to have an opportunity to come back, and as long as I stick to my job description, I'm going to be here, right. Kind of thing. Or if I'm and also with support built in. So what does the person need from the employer in order to be successful? So perhaps maybe getting up in the morning is really hard for the person because of whatever challenges. So maybe they need their job adjusted from 9 to 5 to 11 to 7 or something. Working with the employer with some open disclosure about what's going to work for the employee on that. But
thank you.
It's just openness and dignity.
So Rana, thank you very much. Catherine, I know you have something to add. We also have a few more questions there coming in just before Catherine adds, but any more pointers for counsellors who may work with individuals with unrealistic job ideas? And then April asks, suggest get information on drug interactions. And so I'll just leave those two questions pondering for people in the room. And Catherine may have some thoughts.
Okay, I just wanted to, that's a great question from a rural community. Just to let you know something that I did with an individual that seemed to really help is I had an individual who was well supported by the employer, and he started using, and he was beginning to, his ability to work was declining over time. and it was making it difficult for the employer to have that person more as less as an sorry, what's the word I want? They weren't able to perform their duties appropriately. And so this person actually ended up being fired. And what he and I did is we went back to the employer with a letter of explaining what his situation had been. This was his choice. And to thank the employer for their opportunity. In other words, to leave that door closed but in with dignity, and so that person could learn from that experience, and for the employer. The other thing that I did was I helped the employer work through what had gone on in that job, what he did well, what didn't go well, and how learning for them to learn. Remember, Kyron was mentioning earlier that people are not going to research. They just want to know, can you do the job or not? So in that situation, I actually did some education. And I think in a rural community, if you can draw on the camaraderie of the community with their desire, obviously, to have people who are able to do the job, which is obviously very important, is to acknowledge what went on. What went on, what went well, what didn't go well. Tell me, as the employment counselor, what can I do next time to be helpful and so forth. In regards to the unrealistic job expectations, that's a really good question. What Lana and I and others have done, and some of those people are on the webinar today, is, for example, I had an individual who wanted to be a firefighter, but he didn't really know what that meant. So I took him to meet with a firefighter, and we did an informational interview. And he spent a couple hours on the job with the firefighter. And he said, you know what, I don't want to do that. On the other hand, that was his choice. I was respecting what his desire was to do. The other thing that I do, which is short and dirty, not fancy, not yes. So the answer is usually yes, no, or I'm not sure. And so from about what you do next. And the other thing I do is I plan with work with people to do a plan B. So if plan A doesn't work out, what's the backfall? What's the backup plan?
Thanks, Catherine. Some really pragmatic and helpful pieces of information there. I just want to respond to this. Can you suggest anywhere to get information on drug interactions? How about I do a little bit of homework, or maybe, Lana, maybe you have
your local pharmacist. They're fabulous. Go in a quiet time and chat them up. And especially if you have specific questions, they are usually more than willing to chat with you and also point you in a good direction. And also, if any of you work with like hospitals that have librarians, for instance, if you are in the city, they will help you and teach you how to use like the databases and show you how to do the research. And they are absolutely phenomenal, and they will also do the research for you. And so that is a really good source, for instance, with Fraser Health or with Vancouver Coastal Health, if you happen to be up here or down here. So that's a couple of places to start.
Thank you. Victor just adds, just want to comment on the quality of the connection with supervisors and managers I've hired and will hire young citizens. The relationship I have with my employees was an important factor in the length of their stay on the job. So looking at that connection early would likely be a good predictor. Yeah. Thanks for that. That's very insightful. Liz says, thanks, I have that situation, and that's exactly how I might handle it, to helping the person to take the lead and address. But it's been clear what my obligations are. It's actually helped him to do the right thing as well. And maybe just very lastly, because I just want to try and attend to all questions if I can at all. Paul says, at times our clients are seeking and just crying out for accountability and moreover a concrete plan. Was there ever a time in your practice that you felt you should have kept the person on the same path for work education but ended up changing it because they said they wanted to? And I see some nods here in the room. And Fern says, thank you to Karen for being forthcoming and sharing your lived experience. Wishing you well in your future endeavor. That's beautiful. And Liz says, thanks for a great webinar. So on that note, I just want to say, keep going vigorously in your work. I hope that you found today helpful. We have 3 super inspiring presenters, and I know one gentleman needs to scoot off and go to work, so how about that for an amazing outcome? Keep those scaffolding strong, and we look forward to seeing you again for the next webinar. Bye for now. Thank you.
Great, thank you.
Right.
It's an estimator job, so I work for a training company.